Hey, everybody, welcome back to Dental Unfiltered. I'm Matt Brown, and I'm here with an awesome guest who I've been looking forward to having on the show for quite some time, Tom Orent. Tom is an old school, super well known speaker in dental and a really big brain. And his brain is really dedicated to a subject that I think is kind of like the holy grail of dentistry, which is cutting PPOs and going fee for service. I think this is one of the scary conversations people have or scary ideas they have. And there's this lots of like chicken before the egg, what's going to work or not work. And for me, it was interesting because the first few practices I ever worked with were all fee for service. So fee for service seemed more familiar and normal to me than PPO. So Tom has a really good story where, when he kind of came about deciding to cut PPOs and kind of like the catalyst event in his life that did it. And I kind of want to start there with Tom. So Tom, tell us about yourself and tell us about like what was the catalyst event that made you say I got to go PPO free.
Hey, Matt, thanks for thanks for the opportunity to share. So the catalyst event is one of those lifetime changes that you never forget. And for me, it was 15 years in a practice, which at this point, I don't even know how many years ago that was. It's got to be 28, 29 years ago. And my first 15 years in practice, I had spent just doing everything I could to become a better clinical dentist, figuring that's what they told us in dental school. Be the very best dentist you can be, and everything else will fall into place. Well, they were close on the wording. Be the be the very best dentist you can be, and everything else will fall. Unless you're looking at the business of your practice, which of course I wasn't, because they taught us nothing about it. So 15 years in, I came within 3 days. It was literally Friday to Monday. So it was 3 days of losing my home and my practice. I was $2 million in debt. I had an office manager who was embezzling me. I had a wife of 10 years who decided she had had enough, and so she was divorcing me. And I didn't end up going bankrupt. In fact, if I had gone bankrupt, I would have lost the home and the practice. And so that Monday, when I realized I couldn't go bankrupt or I'd lose everything, um, it was a turning point. I was in a bunch of PPOs. I had one practice at the time, and I decided to try to dig out because I had no other alternative. It took a couple of years of just a lot of trial and error, bringing kind of business ideas into dental and figuring out how can you make that work. And each of these ideas, I end up in later years, I called each of these ideas gems, which is how the 1,000 gems and gems guy and all that stuff happened. Anyway, part of my process of turning stuff around involved basically 4 different areas. And I did this in a second practice, which was my dad's practice a few years later as well. They're not in any particular order, but one of them is what you do, which is adding a ton of new patient flow. So it's funny. You see these threads online where the docs say, "Yeah, I want to get out. I'm being crushed. I'm losing 30%. I'm losing 35%. Some of them are losing 40% or more to the fees. It's just absolutely insane. But I'm afraid to get out because I think I'm going to lose all these patients." Well, the truth is you're going to lose some patients, and how many you lose is not predictable. And so the 4 things are: number one, add new patient flow before, dig your well before you're thirsty, like the name of that book. Number two is look at the back door, recall retention. So everybody's doing, Weave or Solution Reach or Lighthouse 360 or Demand, or one of those. Dentrix Ascend has a one as well. And those are all good for bringing people back in, and you should be using those. But there's a lot more you can do to reach those who are non-responsive to traditional means. That's number two. Front door, back door, number one, number two. Number three is look and see what other services or treatments that are simple that wouldn't take, you don't have to invest in new equipment. You don't have to take some new continuum. You don't have to leave your practice for weekends at a time to learn it. So simple stuff that you could add that right now you're either not doing, or maybe you're doing, but you're not doing consistently, all of which you feel that these would be benefiting your patients. So I would do those as well. And then number four is real straightforward. Increase your case acceptance. It doesn't need to be by much. I'm not saying, go from 40 to 60 or 60 to 80, wherever you're at. What I'm saying is measure your case acceptance and then work on verbal skills across the board, across the different things that you're offering. Let's say you're a solo GP, and you can multiply this by 2 or 3 or 4, however many docs you have. But let's say you're a solo GP and you've got a $1.2 million practice. Well, if you got a $1.2 million practice, and this is going to vary, but let's say you're proposing $2 million a year in treatment. Okay, so $2 million a year, and let's say you tweaked your case acceptance by, I don't know, 10% would be $200,000, 5% would be 100,000. I mean, you're looking at a six-figure bump. So those are the four areas, and whether I would suggest that you do one or even maybe all four of those before you start dropping out of PPOs depends on where you are on we look at about 24 different KPIs, but it really depends on where you're at: patient flow, busyness, what percentage you're in PPOs. So one of the things, and if you're writing anything down, I would write down, what's your percentage of patients who are in network with one of your PPOs? A lot of docs don't really have a clue where you're at on that, and that's an important number to know. So let's say you're fortunate and you're in the minority and you're only 20-30% in PPOs and 70% of your patients are fee for service. That's going to be a very different scenario and different recommendation on how quickly I would start to get out. Let's say you're heavily into PPOs here. When I took over my dad's practice, after I turned mine around, my dad was kind of the rest of my story is my dad was dying of cancer. He was only in his mid 70s, but just out of the blue was diagnosed. And he had a practice. He was not a dentist, but he was a businessman, owner of a practice about 45 minutes from mine. And unfortunately, he had no money, no savings, no retirement. He had nothing set away from my mother. And all he had was debt. And he called me into the Mass General Hospital, and he didn't call me in. I mean, we were going and visiting him frequently. So he was at the Mass General Hospital, and I'll never forget this. My wife, Elizabeth, and I sat by his bedside, and here he is dying, and he pulls out this legal pad, huge legal pad with a scrawl all over it of all these notes about the practice. And he had never really told me where he was at financially. I knew he was having a stressful life, but he didn't want to kind of tell the kids, what's going on. So now he had to, and he kind of detailed what was going on. And basically he said, I need you to take over the practice and help your mom out. Well, we were doing really well financially and could have just closed that practice and just taken care of my mom. But I promised him I would help. I would turn the practice around because he wanted to see what he had started followed through. And so he passed away. My wife, Elizabeth and I set out to Worcester to that practice. This is what I call my negative inheritance. On day one, I sat down with each of the different departments, but I remember he had a big practice. He had 11 chairs, 3 GPs, 2 specialists, a huge support team. And the more dentistry they did, the more money they lost, literally. And so I sat down with the bookkeeper. Her name was Sue. And I said, Sue, my dad, said that he may be behind on some of the lab and supply bills and things, and we should talk to you about that. So she very shyly said, Dr. Orent, she said, we're so far behind. He had been sick for a while, didn't really know where he was at. She said, we're so far behind on bills. She said that unless you write us a check and catch us up right now so we can pay off the lab and supply, we're going to get shut down. So I said, well, Elizabeth, my wife, she has her checkbook, and she opened up her checkbook. She's happy to write you a check. Hey, can you add it all up? What do you owe? She said, Doc, I already did add it up. She says, I need you to write me a check today for $100,000. So he was behind on the daily
bills. That was
bills.
a lot of money in dentistry back then.
That was 200
and now. It's a lot of money now. It's a lot of money back then.
So, but you're 100% right. So if you take that, I've never done the math, but I know it's more than double the cost of money over that period of a couple of decades. So that $100,000 check that we wrote that day would have been a little over $200,000 just in not paying your bills. All right. So, and he couldn't pay. I mean, he didn't have the money. And so then we sat down. Here's another part of the story you've never heard. We sat down with the dental assistants. So, there's like 5 dental assistants or whatever. And they said, Doc, we don't really know how to, and they were saying it really quietly. We don't really know how to say this, but 2 out of 3 of your general dentists, and now they're my general dentists because I just inherited the practice. 2 out of 3 of your general dentists are committing malpractice on a daily basis. It's like, how is that? Anyway, so I'm not going to go into all the details, but I looked into what they were claiming, and they were right. And within a week or so, I had to terminate. I talked to them, and they said they would never do it again, and then they started. Anyway, so 2 out of 3 general dentists had to be terminated. Now, he had, getting back to PPOs and getting out of PPOs, he had 15 PPOs, and it was 95% of his practice. So, and he was in debt. I mean, this is a terrible financial situation and overwhelmed with PPOs and losing their shirt. So before my dad passed away, he said, Tom, he said, please just don't start dropping all the PPOs at once. He says, because that practice won't survive it. I said, I understand. So I got out there and we started doing exactly what I just said, those 4 different areas that we looked at in my practice, and we looked at those in his practice, started working on those as well. But we had some stumbling blocks, some roadblocks that I didn't expect. You know how you were saying, you were used to fee for service. I was used to fee for service now too, because I had dropped all my PPOs in Framingham. And so I had a fee for service, 100% fee for service practice, although I'd come from PPOs. Um, but in Worcester, basically the team told us it's not going to work here. What you did in Framingham will
Yeah,
not work
I
out
hate
here.
when I hear that. I think
It will.
it
You don't understand. It won't work here.
yeah, you
It
hear that
won't
from
work.
teams all the time.
It won't
Like,
work in this
this doesn't work
location.
in this these people are different. They're not.
Our patients are different than your
No, they're
Framingham
not.
patients. It's almost like you were a fly on the wall, but of course you weren't
No.
listening. You just know the spiel.
Yeah,
So I
they're
said,
not different.
tell me about the patients. So they said, well, there are 3 major factories in this area, and we're in a strip mall, and we service a lot of the people from those factories, and the unions, and the insurance is terrible, and the patients don't have any money. And if they did have money, they wouldn't spend it on their teeth. So
They're not
I
putting
was,
value, right?
yeah, I was
Yeah.
faced with this like stone wall. Um, Meanwhile, what they didn't know was backtrack about 15 years prior, and I had already proven that it would work in Worcester, because what these were people who had my dad had probably hired in the last 5-8 years. There was, and you've never heard this one either. There was an outbreak of hepatitis C in Worcester. It was a terrible outbreak, and I can't remember exactly the date, but I'm going to go back. Maybe it's more than 15, 20 years ago. It was a while back, and actually, it was way more than that. It was probably 25 to 30 years ago, because 15 or 20 years ago, I'd already sold the practices. So about 25 or 30 years ago, there was an outbreak of hepatitis C. 2 out of his 3 general dentists at the time contracted Hep C. And when you're a dentist and it's in your blood, Hep C, you cannot practice. And I forget how many months, it's got to be clear, but he was really hurting financially at that time. So he reached out to me. This is back when he was fine health wise. And he said, we're getting crushed with 2 out of my 3 general dentists being down, and who knows how long they'll be out. Can you come in? And again, this is kind of like when you watch a TV show and they show you, oh, back in 1973 in October, and then they show you a scene from that. Well, this is going way, way, way back. And he said, can you come out and give me 1 day a week? And he knew I was crazy busy in Framingham, but so I said, fine. So I rearranged my schedule so I could give him 1 day a week of production. The morning I got out there, those dental assistants basically said the same thing, which is, your type of dentistry just doesn't work here. My type of dentistry was inlays, onlays, crowns, prosthetics, quadrant dentistry, doing a quadrant, taking an impression, sending it in, and then placing it. And so, and I also did a lot of cosmetic work, a lot of veneers. I was accredited by the American Academy of Cosmetic Dentistry, which, by the way, I thought that was great because, clinically I'm doing nicely, but meanwhile I was losing my shirt at the time. So there's this 2 faces of me as a dentist. The outward face was I had a beautiful office, and you and I have talked about this one. I had a beautiful practice that was designed by this architectural firm that does top end dental offices, and I had all the trappings. I was, Dawson. I went through 2 years at Dawson. I went through every Strupp course. Love Bill Strupp. Love Pete Dawson. In fact, Pete wrote the foreword to one of my books. So I had all these accolades. Meanwhile, I was losing my shirt. Couldn't afford to feed my family. And uh, it's not only that I don't mind telling this story, but I want to tell this story because I want other dentists to know that whatever you're going through, if you're having a tough time, many, many, many of us have been through it, and a lot of them because in the local dental societies, nobody's honest. Yeah. You go to a local dental society meeting. How are things? Oh, things are great. Thanks. Yeah, things are great. Meanwhile, I'm 3 days from literally losing the practice.
Yeah.
Things are great.
I
Looking good.
I
Anyway,
think
back to that day
dentists,
when
yeah,
I,
I think with that thing, I think dentists get really fixated more on what their colleagues think than focusing on, like, how to really fix the mess and improve themselves. Like, not I think so, not to interrupt you, I think that I think traditionally in dentistry, if you think about improving yourself as a dentist, the default is CE courses, right? That is the default, like standardized thinking in the industry. And I think, say, improving yourself in a dentist, I think there is a little bit of shift coming. I don't know if you know. Do you know Alan Stern?
of course,
Yeah, yeah, Alan. Alan has his book, and I think now there's starting to be a change where like improving yourself as a dentist also means mindset and some other stuff and healthy living and longevity. I think it's starting to creep in today. But at that point in time, it had to have been the thinking was clinical, 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 and business. I think at that time, not to insult that time period, I think you could be successful accidentally as a dentist then, but you also could accidentally have a catastrophe and very, very unintentional.
Here's the proof. So I'm sitting now when my dad's passed away and we own the practice and they're telling us, your type of dentistry won't work. You can't get out of PPOs, all these false beliefs. You and I had a conversation for about an hour one time where we just talked about all the false beliefs that are in our heads. And the scary thing about false beliefs is there's two things. Number one, we believe them. We believe they're true. We don't believe that they're a false belief. We believe they're true because that's the definition of a false belief. Number two is false beliefs will 100% stop you from taking action on something that you could fix because you believe it can't be. So now we're going back that 28 years or whatever with the Hep C breakout. My dad's still running the practice. He's healthy. I'm out there on day one, and they're all telling me, the assistants are telling me our patients won't accept that kind of care. They just won't. So I ignored them, and I did my thing. And on the very first day I was there, I got a quadrant of it was like either 3 or 4 teeth. It was a young man in his 30s. He was wearing, as they described, one of the blue jump alls with the yellow name inscribed on it from the local factory. I mean, he was exactly what they described, except for his mindset was different. He was open to hearing if there was something better that would last longer, that would be better for him health wise. And so he accepted a quadrant of inlays and onlays that were they were all lab fabricated white inlays, onlays. At that time, it was porcelain inlays and onlays, and no insurance didn't cover most of that stuff. And I told him honestly, okay, so without getting all the details of the presentation, the point is we have a lot of beliefs in our mind about what our patients will and won't accept, what we can and can't do with the practice. So very slowly and carefully, it took 2 years in that practice, but within 2 years, I had eliminated 13 of his 15 plans. And when I sold that practice and took care of my mom out of that, and when I sold that practice, I kept 2 plans. And some people have asked me, you got 100% fee for service in Framingham. You dropped 13 plans out of Worcester. Why did you not just go 100% fee for service in Worcester? So the truth is, I didn't leave plans so that I could say I was fee for service. I left plans because they were abusing us financially. They were abusing my team's time. They were downgrading and denying things that were obviously in need, but they just have algorithms that do that. And then you want to speak to a dentist, and you speak to that dentist, he says, sorry, I can't do anything for you. That one's so the two that we kept were actually paying us well, paying decent fees, and treating my team well. So we kept two. When I sold that practice, it was about 90% fee for service, and we had those 2 small plans. So that's my story.
It's interesting, there's so much there to unpack. And I think the false beliefs thing. And honestly, in my life, I'm guilty of this. I mean, I'm sure listeners know I'm an amputee with one leg, and I have limitations in the world, and I get false beliefs just about my daily life and about my limitations that aren't real. Meanwhile, I started rock climbing again, and I just completed my first overhang with one leg. And I think if you relate that back to dentistry, like we create these false beliefs. I think sometimes the false beliefs are created so we can justify our own shortcomings and our own like our own inability to perform the way we think we should be. Um, it's so funny. The first time I ever presented live was based around a group's false beliefs. I was energized, had like 10 clients at the time. We were a brand new company, and I had a client in Tennessee who's still a client to this day. And he called me and said, "Matt, this doesn't work here." Same thing. And I showed up, and each staff member took me into office one at a time or an op and said, "Hey, man, this might work some places, doesn't work here." I'm like, "What do you mean? Like people? I don't understand. Like these people are different. Everyone says like our patients are different here. No, your staff is different. You're different." So long story short, end of the day, office manager did not like me. End of the day, she walks up and says, "Hey, Matt, you wasted my time again. Straight crackhead in the chair." She said that to me at the front desk. I turned. I said, "Cool, give me the chart. I'll go in and present." And she looked at the docs, can he do that? And doc said, he already said it's a waste. Let him go. And I had never presented before ever in my life. I never had. And this is my first time, like, ever in that realm of walking into an operatory alone with a patient to present treatment. And I walked in and talked to the lady, and they weren't wrong. The lady was in recovery. She was sweet though. And after I, talked to her and navigated the human part of it, she said, "You're the first person in dental practice who treated me like a human." She said that her boss told her that he would pay for the dental work and take it out of her paycheck. And I was like, cool. And I came out and I said, here's her credit card. She can leave a $300 deposit. She wants those snap-in denture things that go in and out that don't need glue. And they looked at me and they go, how'd you do that? I mean, what do you mean? I didn't know how much snap-in dentures were. And they said they're $20,000. Well, this is the deal. You know who didn't have any belief? This guy. And you end up creating these scenarios because of your false beliefs that become reality because you let them guide you through the process and dictate what you do. And I think as a dentist listening, if you are going to go down the path of like cutting PPOs or making any large change in the practice, any kind of large change, whatever it is, PPOs, whatever it might be, right? And people around you start saying things like, Doc, our patients are not like other patients. We shouldn't do this here. You should seriously consider that brain and what it's doing in your practice and either try to change its mindset or you might have to change the person because that is the limiting factor. One more thing about this, and this is the proof of this. North of Houston, in the Woodlands, years ago, we had two practices, and one was struggling really bad with us, and one was doing great. And they're 4 or 5 miles apart. And we had patients go from one practice to the other and accept really high dollar value treatment. And the one doc's like, this doesn't work here. Well, if you took the people, forget the buildings, forget the patients, if you took the teams and lifted them up and moved them between the practices, the results would move with the teams. It would change with the people, right? So it really, like, a lot of this comes down to your beliefs. So I'm going to ask you another question real quick. So um docs are out there, right? And I talk to docs every day, and they come to us because they want to go PPO. They want to go fee for service, or they want to drop PPOs and swap them out for new patients, right? And there's always this chicken. This actually happens in two scenarios. It also happens with adding an associate. There's always this like, how long is my income going to get hurt? What is the risk? How do I mitigate 100% of the risk? I hear that all the time. I hear all the time. How do I just not lose the patients? How do I add an associate and not have my schedule impacted? And the reality is you can't. Like there's no risk scenario for these big moves. So if you were talking to a young doc who's like, I want to cut my bottom five worst PPOs, not just from a fee schedule point of view, but like you said, from a quality of the workday from my staff point of view, which is really critical to this, right? It's easy to look at fee schedules and cut, but get your staff's feedback. What would be the advice you tell him to give him confidence to be able to start that process? He's scared. He's scared out of his mind of it. Tom Orent is the greatest PPO guy ever in the history of dental ever. He's lucky enough to get a phone call with you. What do you tell him to help him get ready to do it?
So it goes back to a couple of things I said earlier. The first thing is I would look at 15, 20 at least different metrics. One of the metric, and I'm just off the top of my head, I have something I call a PPO drop assessment. So are you ready? PPO drop readiness assessment. This is one of the things that I do with my members to find out what would I suggest, because there is no cookie cutter, but I'll give you some. They're all different. So I'll give you a little bit of the flavor of that. So one of the things I would look at is um, if you drop some PPOs and it goes bad and you lose more patients than you ever were even afraid you were going to lose, and now you went from a pretty profitable practice to no profit, as in you just have enough to cover your expenses, but you're making zero. So now your paycheck is zero, and that's not changing for any time soon. If that worst case scenario, of course, the worst case scenario is it goes worse than zero, but let's say you go to zero, so you have no profit. How long could you survive on what you have in the bank? So it's a critical thing because so much of this has to do with mindset. You can drop PPOs, improve your practice enough ahead of time, and then during that, and train your team and yourself on how to do the transition smoothly enough to not eliminate the loss of patients, but to minimize the risk, to minimize the number of patients you're going to lose. and to maximize profitability along the way. And some of the docs I've done this with see a dip and then it goes right back up. Some don't even see a dip because they're prepared for it well, and so it just goes up. And I'm sure there's some who I don't know who have made a lot of mistakes or not done some things that they needed to do. So let's go back to your young man who's asking the question, "What should I do?"
Yeah, give him confidence. He's terrified. He needs to do it. He's getting hurt. He's terrified.
Yeah. So the first thing is, how long could you survive? If he says, "Well, the truth is, I had this other job, some other thing before this, and I put a lot of money away, and I could survive for a year or two with no income," then my answer is going to be totally different than it would be to the doc who says, and by the way, more docs than not don't have a year or two of money put away. More docs than not say, "Well, I have a new baby on the way. We just got into a bigger apartment or house. And so money is bleeding out of every different direction. And I couldn't probably survive more than a few months." Well, then my recommendation is going to be very different. Now, I can't go by just that one number because another question I'm going to ask, and if you're listening to this podcast and saying to yourself, what would Tom do in this situation? One of the most important questions I would ask would be, how far would I have to look out in your schedule, the doctor's schedule, before I find any openings? As in, you are jam packed, cannot put anybody. Okay, so that you get a wide variety of answers on this. There are some docs who tell me, I've got literally no place to put anybody for 2 or 3 months. You cannot put anybody in, even blockouts. Those are all gone. There's no place to put anybody in my schedule for a few months. Now, the other end, and it's a continuum, but the other end of that spectrum is, I got openings this afternoon. So for those who are not well booked, solid booked out for at least a few weeks, you're going to really feel when you start dropping PPOs, no matter what you do. Energize gives you a bunch more new patients. You do recall retention. You increase your case accept. You do all the 4 things I was talking about before. That's all good. And I would still do all those things. But if you're already super light in your schedule and you start dropping PPOs, it's going to be a tough roll for a while. And I'm not sure that I would even recommend it at that point. In fact, I probably would not recommend dropping at that point. I would recommend fixing the practice first before I try to drop out of any PPOs. Now, let's say you are booked out for at least 3-4 weeks, maybe even 5 weeks, whatever. There's no place to put anybody. And you say, "I'm so jammed out, would this be a good time for me to just start dropping?" My answer would be another question. And this question is, what is the percentage of patients in the smallest PPOs that you have? Oh, well, I have this one that has 3% of my patients and this one that has 8% of my patients. Cool. Go ahead and drop those two, because if you're so solid jam that you can't even accept a new patient, by the way, Matt, you tell me, you tell our audience, what happens to a practice when they put any money into marketing, but there's no place to put those patients for 3 to 4 weeks out?
What happens is, it's such a good question, Tom. So new patients expire. So what happens is, I would love your input. We believe there's a 10-day or less time clock, right? And what happens is, so I'm a new patient and I'm deciding today that I want to call a dentist. Well, I'm not going to wait 3 weeks to meet somebody who, one, I'm scared of, and two, I have no human equity with. I'm going to call the next place till someone gets me in. I believe you need to get them in 10 days or less. And a lot of times, staff and docs say, "Well, I'm booked out 3 weeks." But I guarantee you there is a way to see that patient.
Of course.
Yes.
But again, it's mindset. It's false beliefs and real beliefs.
100% false beliefs.
So I would say that your 10 days is way too long.
Okay, cool. Tell me. Listen, I can be wrong. Tell me. You know more than I do.
There's no right or wrong. This is just my belief. I told my team member, we had 35 team members. I told my team members, excuse me, and we tell our practices we work with now, when there's somebody on the phone who wants to come in, you offer them today or tomorrow. Now,
okay, that's aggressive.
You offer them today or tomorrow, because, well, think about it. Again, it's a continuum. What's the likelihood that if you offer them 3 or 4 weeks, okay, so you already said that they're not coming, or if they do schedule, they're no showing.
They're no showing. Your no show rate's so high. Well,
Yeah. So
we've found after 10 days, the no-show rate skyrockets.
yeah, it's useless. You're
Yeah,
hurting yourself by
yeah.
even scheduling them at that point. You're right. So because it's a continuum, there is no, okay, it's day 7 or 10 or 12 or whatever. We just say, offer them today or tomorrow. Now, if they say I can't because I'm going on vacation, I won't be back until Tuesday, or I've got this work project, that's fine. If the patient doesn't want today or tomorrow, that's fine. But what you're going to find is this is the weird thing, the psychology of being a patient. So the patient hasn't been to a dentist in 6 years. As you said, they're afraid of it. They don't want to spend the money. They're fearing the pain, whatever it is. The patient hasn't been to a dentist in 4, 5, 6 years. The moment the patient makes the decision in their head that they want to see a dentist, they want it. They want to see a dentist now.
Pull the trigger now.
Yeah, and the worst thing you can do is schedule them out a week or two. All right, so we agree on that. So even those practices, this is kind of an aside, but even those practices who are crazy busy jammed, the first thing I recommend for you and for docs I'm working with is real simple. Put new patient blockouts into your schedule as soon as you can. Now, maybe you can't do it right now. Maybe you can't do it for I don't care when it is. Maybe it's 3 weeks out. You got to put new patient blockouts in. And how many is a real simple answer. Your average new patient flow per week. So if you get,
Yeah.
if you get,
50 new patients a month, 12,
yeah,
12 a week, right? Something like that.
whatever,
13,
do your
yeah,
math,
yeah.
do your math. Oh, I can't put in 12 new patient blocks a week. Well, if that's your new patient flow, then you need to do that now. Now, that does not solve the problem between now and 3 or 4 or 5 weeks out if they're jammed up. And don't let me not get back to this young man who is jammed up and has these two small PPOs, because we got to talk about what to do with those two PPOs, because you don't just drop them. I said drop them, but you don't just drop them.
There's got to be a
Right.
process. It's not just turn the light
This is the
switch off.
point.
Yeah,
There's an optimal process.
yeah.
So, but let's go back to this jammed out person. Um, a lot of docs look at this situation of being that jammed up, and their belief in their mind, again, a false belief, but their belief is there is really no place to put anybody. Great. How many days a week are you working right now? 4. So let me get this right.
With
You
20%
spent
capacity.
$800,000. You spent $800,000 on your education. You spent another 800,000 or million or whatever it is to buy the
Million
practice.
plus now.
You spent you needed to re-equip the ops, and it turns out that none of the computers that the old doc had would work with the new software that you got for practice management. And between IT and revamping and yada yada yada, the cost of you're 5 years into practice and you're $2 million in debt. And you're telling me you're working 4 days a week and golfing the other day? It's like, seriously? So I knew a dentist many years ago who, when he got out of dental school, the way he paid off his loans was he took 2 full-time jobs. He had an associate job for 40 hours a week, and he had another associate job for 40 hours a week. So he was working 80 hours, two full-time separate jobs. Um, I had a patient. From Brazil. He worked 3 full-time jobs. He almost never came in because there was no time for dentistry. But when I did see him, an emergency here and there, he would tell me about what he did. And what he did, and he had 3, minimum wage full-time jobs. He only took Sunday mornings off to go to church mostly, and other dental emergency, whatever. But and he was sending money home to his family in Brazil. But he was working 3. So when we're working 1 4-day week and we say we can't, okay, so here's what I would do. Just make it a temporary thing. Add 1 day a week just temporarily and block it out for new patients and major cases.
So what I believe is 2 things. One, going back to the doc playing golf with all the debt. Okay, I believe,
And driving a beautiful new BMW
yeah,
to that golf course
to that
with
golf
$2 million
course.
in debt.
Yeah, and I believe I believe you guys. I would say we. I'm not a dentist. You guys become dentists, and there's a lifestyle they believe has to go along with that, and that becomes an anchor that sucks up resources and holds them back. Okay. Second, I believe the doc that opens up the 5th day a week will ultimately, as he does a couple months of that, will look at the 4 days a week and go, well, I could side book 3 patients a day and not have to do this 5th day a week. And they'll actually find a way to get out of it. And then they'll look at the 4 days a week differently. The deal is this: docs always want to grow, right? and like, I want to grow, but they don't want any stress and discomfort in the growth. Guys, if you're listening, okay, if you're listening, there is zero growth without stress and discomfort. Zero. It doesn't exist. Not in any part of life, any opportunity, anything. It doesn't exist. So, Doc, if you're here and you're looking for like a cush lifestyle and not having to deal with all this and no stress, you should have stayed an associate. You should have stayed an associate, chipped away your student loans. And the deal is this: not every doc should own a practice. That's a false thing. It is. There's nothing wrong with not owning a practice. But I think the doc that would ultimately go to 5 days a week after 2 months would be like, how can I do this on 4 days a week? I would want to get rid of the day anyway. That's what would happen. And they would fight the 4 day a week, 12 new patient thing until they did the fifth day. And I believe they'd probably find a way to try and not do it.
On the line of getting super busy and going to a fifth day and all that, a lot of docs get busier and busier and busier and jammed out and accepting more and more PPOs, and then they add an associate. Well, it's really expensive to add an associate, especially if you need to, and you usually would, add at least 2 more full-time team members, maybe more, but at least two more full-time team members, one clinically and one in the front, and probably more than that today. And then you look at how much you're writing off to the PPOs, which again is 30, 35, sometimes 40% or more, and then how much you're paying the doc. And what they do, this is what happened in my dad's practice. He built a bigger and bigger and bigger machine with 11 chairs and the 3 GPs and the 2 specialists and this huge support staff. And the more dentistry they did, the more money they lost. And so bigger isn't always better. I read a thread on Facebook this morning from a post by a doc who said that he had gone fee-for-service recently and had, I think within the last year or so, and he had seen a significant dip in his busyness. And he looked at his top-line revenue, top-line production, and his top-line production was significantly down from the prior year. And he said, the interesting thing is, I'm working less, my expenses are lower, and my profit is much higher, and I'm much happier. So again, I'm not saying you need to have a big dip, but it does happen, but you can still be more profitable. So let's go back to the young man who asked, what should I do? And he identified that there are 2 very small footprint PPOs. One's 3% of his patients, one's maybe 5 or whatever. And I initially said, well, if you're jammed out 3, 4, 5 weeks, there's no place to put anybody, and you've got a couple of really small PPOs, the first thing I would do is get rid of those. So that's true, but I should say that's true and. So, and you need to do it with the most optimal process that exists. And I'll describe how I did this in both of my practices and what we've done with all of our members who've either dropped 1 or more, because you don't have to go fee for service. If you just drop 1 or 2 PPOs, you're going to be more profitable. All right. So and that's usually the way most people go, is just to start chipping away at it. Maybe you're 80% PPO, and then in a year or 2, you're 60% PPO or 50%. That's a great increase. And decreased PPOs increase in fee for service. So what is the process? Well, one of the most common mistakes, I'll give you the 2 most common mistakes that are financial killers when dropping a PPO. Number 1 is notifying your patients any way other than in person.
Yeah,
I
I was gonna ask you about that actually, because I agree
Okay.
with you. You do it
Yeah.
chairside in the practice,
Yep.
person to person. You don't send a letter or an email.
100%. 100%. If you aren't doing it this way, then you're cutting your nose to spite your face. You're trying to achieve something and minimize the loss, and meanwhile you're going to maximize loss by emailing or sending a letter or even a FedEx. I don't care how you do it. If you do anything other than if you're writing anything down at all, if you're a doc and thinking of dropping a PPO, write down knee to knee, eye to eye, toe to toe. This is what I call the speech. I call it my knee to knee, eye to eye, toe to toe speech. And it should only be done, in my opinion, by either the doctor or one of the hygienists, because you are the ones who have the hands-on clinical, taking care of them. You're the provider. So now, if there's no way to do that, fine. You got a mega practice and you can't, that's fine. But preferably by the doctor of record who treats that patient or the hygienist who treats that patient. So mistake number one is the modality. It's got to be knee to knee, eye to eye, toe to toe in order to maximize. Um, don't let me forget to circle back on what happens with the people who you can't get to in that. And then number two mistake is the timing of when you notify the PPO that you're dropping them. Guess what happens within 24 hours? And this is just an automatic trigger in their system. It's an automation. Guess what happens within 24 hours of the time you notify a PPO that you're leaving? What do you think they do?
They notify your patients.
They notify the patients. That doesn't even require a human. It doesn't even.
Really?
They will send a terrible letter to your patients, and that letter says something like this.
Really?
Oh, it's the worst. Some of my members have shown me these letters, and it's just the worst. Dear
They
Mrs.
have no loyalty to you.
Dear Mrs. Smith, currently, no, you have been seeing Dr. Tom Orent. He was with our PPO in network. However, at this point, he is no longer considered a preferred provider. Like I did something wrong. Like he is no longer on our list of preferred providers. All that means is I drop them. But the way that they would word it, put it this way: if you're a multi-billion-dollar corporation, you're going to have plenty of the best copywriters in the world working for you and writing the most dreadful, harming, poisonous letters they can. And then it's going to follow up with, these are the reasons that you should be seeing an in-network provider, yada, yada, yada. They'll go through that. And by the way, here are 12 in-network providers who are within, half a mile of.
Here's a list of your competitors that take your PPO.
Yeah. So, okay. So
that's so horrible.
Yeah, but I sidestepped the whole process. I did it in both practices. It takes patience, but if you have patience, you'll optimize your result. So have some patience and do not notify the insurance company until you've spoken with all the patients first. I want you, the doctor, I wanted our doctors, we had 5 GPs. I wanted us to be the ones to talk with these patients before they got that terrible letter.
The letter has a negative connotation. That's not real.
Yeah, so I want to make sure we've already had the conversation so there's no surprises to the patient. The patient's already made a decision based on the relationship. All right, so let's talk about the discussion. How do you actually do this? So it's a very short discussion. This is not something that's going to take you 10 or 15 minutes per patient. It's going to take you about 2-3 minutes, 4 minutes at most. So normally, if I walk into an operatory or when I walk into an operatory and I'm about to say hi to a patient who is back for treatment or whatever, recall, we try to do this on their recall cycle if possible. So that's why we do it over a 6-month period. It takes a 6-month recall cycle before we've got a shot at getting not all, but most of the patients who are in network with that particular PPO. We've had the discussion, either the doc or the hygienist. So normally I would walk into an operatory and I'd say, hey, Bob, how are the kids? How's Betty? And how was that? You guys went on a trip last week? And whatever. It would be all the upbeat, normal, small chat. I eliminate that 100%. And I walk in, straight face, not big smiles, shake his hand, shake her hand. And I look at him eye to eye, knee to knee. I sit down. I look at him knee to knee, eye to eye, toe to toe, and I say, Matt, I just wanted to thank you for telling you how much I appreciate you and your family having been patients with us for over the years. And I stop. And I stumble, by the way. I don't know if you notice how many times I stumbled on that sentence. That was something in sales and marketing, and I'm sure you know this. Stumbling is an actual strategy.
Yeah, it's not robotic. It's organic. It's emotion.
I just wanted to tell you, I want to express how much I appreciate having had the opportunity to have you and Betty and the kids as patients over the years. And I say it just like that. And I'm telling you, we got really good at this. We dropped a lot of PPOs. Got really, really good at this in both practices. And I pause, and I'm getting goosebumps because when you say that like that, with those words, with that tone, what do you think is racing through there's about 2 or 3 thoughts that are racing through the patient's mind. What would you think if I said that to you?
Maybe you're leaving.
I'm leaving. I'm retiring. I'm sick.
Yeah.
I have terminal cancer.
That's the first thing that comes to my head is like, this is you saying goodbye.
There's something going on here that's not good.
It's not good.
Something bad happened. Something
Yeah.
bad happened. Because normally
It's an opener for prepping the landscape for a tough conversation.
when I did this, it was just so cool because the reaction was always the same. They would kind of like that. Now, I didn't let them stew for too long because I didn't want them to think I'm dying or something. So
How important is the uncomfortable silence?
critical.
Critical, right? So listen, I teach case presentation all over the country. The number one thing is people can't handle the awkward silence. And it's the most, I don't know, but I think it's the most important part of it.
It's critical. It's part of the script is not saying anything.
Yeah. That's a really important part. I don't think it's the most effective, actually.
Have you ever watched either in a movie or in a Netflix series, something that you really, really like and you're really into? Right now, my wife and I just watched the third season of The Diplomat. I don't know if you've been following The Diplomat or not, but some of their silence things, they're and they're doing that. I don't want to do this too long because some of these people are probably just listening, not watching, and think that we just got cut off, but we didn't. It's just this. Okay, so anyway, after I let them stew on that just for a second or two, um, basically I say to them, it's super short. I say to them, we've come to the point. You have ABC, Acme, PPO, and we've come to the point with Acme where uh, we're no longer able to deliver the level of service, the high quality care that you expect. Not only do you expect it, you deserve that level of care, and you expect that from us. And we can no longer do that at the compromised fees. Now, notice there's a lot of words in there that were critical. You have this XYZ, you have this particular insurance company, and we've come to the point where we can no longer deliver the level of quality care that you've come to expect and true, frankly, you deserve from us, and we wouldn't ever offer anything less. We've come to the point where we can no longer offer that level of care with the compromised fees. So uncompromised level of care with the compromised fees that we're receiving. And so we've decided to leave the network. Now, the good news, now we don't, by the way, we don't let them answer. Now there's no pause.
No
We
pause.
don't let them
Because you got
respond.
to get to the next part of this, which is
Yep.
critical. Because they're already thinking I have to leave, and now you got to
Bingo.
deliver that you don't have to leave.
Bingo. So we can no longer do that with the compromised fees, uncompromised level of care that you come to expect and deserve. The good part of this is in their contracts with the state, in order to actually perform their services as a PPO, they are required to allow you to continue to see us and provide benefits. And so you won't have to touch an insurance claim. You won't have to submit anything. We'll take care of all the paperwork. And Lucy, our insurance ninja, write down the word insurance ninja if you're writing anything down. Lucy, our insurance ninja, will continue to maximize your benefits even when you're out of network. So, really, on the surface, nothing will change. There are two changes. The only two changes you'll notice are you'll be paying a higher fee because out of network, it's a higher fee. And the checks will go directly to you. So we'll be asking you, and we can work out financing if it's more comfortable. But the checks will go directly to you from the insurance company. And I will tell you that when we had these conversations in that manner, which is exactly what we did really, really well at retaining. Now, no matter how good you are, no matter what you say, no matter what words, doesn't matter how good you are, you're always going to lose some patients. And I will tell you that any patient who would leave you for just that reason. Oh, so we're gonna get the check and it's gonna be a higher fee. Well, we're gonna go somewhere else. They were never your patient. They were never your patient. They were the insurance company's patient.
So we have to wrap up here in a second. One other thing with that, the patient that would leave over the fee schedule changing from in-network to out-of-network benefits is also, in my opinion, probably a low average patient value patient because they're only accepting treatment each year up to their average benefit and they never want to take money out of pocket. So that's actually a patient that you should be happy to let leave. That should be the one you're excited about.
You're 100% right. So one thing I know we got to wrap up. I said there's one thing I didn't want to forget, and that was what do you do at the end of 6 months when you haven't spoken to everybody because you've still got some people who didn't come in on recall during that 6 month cycle. This is an easy one. And by the way, you don't have to speak with everybody. There's like 2.3 or 2.5 people per family in your practice. So you only have to speak with mom or dad. So, and you don't have to speak with both. So it's not that many conversations. But what do you do with those who you couldn't get? Well, let's say there's 50 families who at the end of 6 months, you just never saw them. They weren't in. You haven't had the conversation, and now you're about to, within a week or so, you're gonna contact ABC or Acme PPO and pull the trigger and tell them you're out. What we do there is the exact same conversation, but by phone, and you split it up amongst the doctors and the hygienists. You could even have office manager, business team, whomever. You get whoever you can on the phones, and if it's 50 families and 5 of you are making the calls, then you get 10 families within a few days. Within a few days, each of you has made your 10 calls, and now you've notified everybody in person. The call is not as good as the in person, but it's better than sending them a letter.
Better than the letter from you. It's better. So we have to wrap up, but in my head, when I was thinking about this, if you get one letter from the PPO that's immediate, that says this person is no longer a preferred provider, which sounds horrible. Sounds like you get a board complaint or something. Then another letter comes that's very fluffy and awesome. It kind of feels used car salesman like. If both letters collide, one then the thing is that the PPO is going to beat you to the letter, 100%. You're not going to be ready for that. So I have always said that you should do it chair side. I think all important things should be communicated chair side, 100%. Like if first of all, and we have to wrap it up right here. But first of all, you should never be communicating anything critical at the front desk. That's a checkout area, not a communication area. But guys, it was great having Tom on. There's a few people um that I get to spend time with and talk to. I don't think me and Tom have had anything ever short of an hour conversation ever. Me and Tom talk a lot in the background, and he is somebody I whenever I can get a chance to talk to Tom Warren, I get really excited. He's right up there with Kelly Schwartz for me. Kelly's, I think, one of the best brains in dentistry. He influenced a lot of dental intelligence stuff. Tom, I think, is the ultimate brain for cutting PPOs and navigating this. And I'm really excited we got to have you, Tom. This has been a podcast I've been looking forward to. We've been talking about for probably a year and trying to get our schedules to match up. And this is probably top 3 podcasts I'm going to record this year that I was excited about. And I'm so thankful you came on, Tom. Real quick before I end the episode, how can people reach you? And anything you want to say before I wrap the episode up?
Probably the best way, I'll give them 2 things. If they want to learn how I can help you, I would go to ppoexit.com/Matt. That's ppoexit.com/MATT, Matt. By using Matt, it'll give you a savings that otherwise you would not get the ability to get. As far as if you just wanted to reach me and ask a question, you could use Dr. Tom, and that's Dr.Tom at Freedom Summit Coaching. Dr. Tom at freedomsummitcoaching.com, and shoot me an email. I'm happy to answer questions.
Guys, if you think about cutting PPOs and you have anxiety about it, but you know it's the right thing to do, there's no better security blanket or training wheels to get you through it than Tom Orent and his information. I invest a lot of my brain in this subject, and Tom is the absolute wizard of this. He is famous. Whenever his name comes up, everyone says the same thing. The Gems guy, I saw him speak 20 years ago, and everyone's like, and he's still going, and he's still the guy.
I got that yesterday.
Yeah, I whenever I talk about you, somebody, I'll be in a room full of dentists, somebody's head will snap around like the Gems guy. I'm like, yeah, the Gems guy. I bring you up a lot in conversations. Hey guys, listen, me and Dr. Vallo and all the hosts here on the channel, we don't get paid for this. This is something we do for the community. Please like, subscribe, share, leave us a review. That's the only thing we ask. There are no sponsors. Tom did not pay to be on here today. I picked him because of how important he is. We try to find you the best guests and the best information, guys. Please like, subscribe, and share. And also, if you look in the description of the episode, there is a link to the Dental Unfiltered Study Club. You can add yourself to it on WhatsApp. And Tom is doing a webinar at the end of this month in November. We'll be bringing him back. I think we're going to bring him back again next year for another webinar. And you can go find out about our webinars there. And the webinars are free to all of you guys. I host them, and we have some of our amazing guests on the webinars to interact with you guys. Thank you guys so much for listening, and have a great day.